Hi, good afternoon, everyone, and welcome to our Sickle Cell Data Collection Program for California's webinar series. I'm Niani Coker from Tracking California's SCDC program, and I'll be today's moderator. We have a great webinar for you today focused on GHPP and CCS, understanding the alphabet soup of California's healthcare. But first, a few housekeeping items. I have muted all of the conference lines to eliminate background noise, and this session is being recorded. The recording link and slide deck will be made available and automatically sent to everyone who's registered for this webinar. We'll take written questions through the chat box or question function on the control panel of this webinar, but due to the complexity of the topic, feel free to ask questions through the chat box as they come up for you. Now I'd like to introduce today's speaker. Lynne Kinst has been the Executive Director of the Hemophilia Council of California, HCC, since January of 2020. Joining HCC was the perfect opportunity to bring together Lynne's passion for advocacy and love for bleeding disorders community. Previously, she was the Executive Director of the Central California Hemophilia Foundation, CCHF. She has also worked for the California State Board of Equalization board members, George Runner and Diane Harkey, and the Taxpayers' Rights Advocate. In addition, Lynne spent 8 years as the Director of Administration with a nonprofit organization now known as Capital Commission. Prior to working at the nonprofit, she has had 4 years of political experience working for state elected officials in a variety of capacities. Born and raised in Sacramento, Lynne attended the University of California, Davis, earning a bachelor's degree in political science with minors in human development and religious studies. Lynne also has a master's of arts in biblical counseling from the Masters University. Her father, Jim Carey, was an active member of the CCHF board, serving as treasurer since the chapter's founding until his death in 1994, and CCHF's Jim Carey Scholarship is named in his honor. Previously, Lynne served on both the CCHF and HCC boards of directors. Lynne herself has mild hemophilia B, and she and her husband David live in Rockland, California with their son Zach and daughter Ashley. So with that, I will turn it over to you, Lynne.
Thank you so much. It's a privilege to be with all of you today, and I just want to reiterate, please feel free as we're going through the presentation today to go ahead and type your questions into the chat as we go, and I will try to kind of keep an eye on that and adjust them. Sometimes it's a little easier, to bring up a clarification when we're in the middle of talking about that point, but also, we will also have time for Q&A at the end. So just a little bit, you heard my bio, but by way of background, as the Executive Director of the Hemophilia Council, we really do a lot of work individually with patients, and as well as social workers and other practitioners at our hemophilia treatment centers. And that is really how I have kind of learned on the job to really understand GHPP and CCS, so that we can assist patients who really can benefit from these services and programs that the state of California provides. And, my sense as I have worked in this space and also built relationships at the Department of Healthcare Services with those that oversee these programs is that, particularly with GHPP, it tends to be underutilized because I think patients and providers don't necessarily really understand the program and the potential benefits very well. And it can make it difficult for patients to navigate. And so anything we can do to help demystify that and help folks have access to these programs is really beneficial. So go ahead and go to the next slide. So just really briefly, the Hemophilia Council was formed in the early 1980s, and we really serve as an advocacy arm for the patients in the bleeding disorders community in order to really ensure access to healthcare and addressing, various barriers and disparities there. In that work, we have done more and more collaboration with other patient groups, particularly in the rare disease space. We have now founded something called the California Rare Disease Access Coalition, and we work really closely with some other sickle cell as well as cystic fibrosis groups and others in the rare disease space on those initiatives. You can go ahead and forward through the next slide and the one after that too, because it kind of reiterates a lot of that same stuff. Okay, so to really kind of start jumping into our primary topic today. So GHPP stands for the Genetically Handicapped Persons Program. Not the most politically correct name. It was created all the way back in 1975. And so we are sort of left with the name GHPP, but really an amazing program. So GHPP is a state-funded program for patients with specific genetic disorders. The three most common of the conditions that are covered are bleeding disorders, sickle cell, and cystic fibrosis. But if you go to the GHPP website, you can access a full list of the covered conditions that are able to access this program. And one of the common misconceptions about GHPP, because folks sort of assume that it's similar to CCS, and we'll talk about that more in a little bit, but GHPP will actually provide comprehensive healthcare coverage. So it covers really any medical care that the patient or the enrollee needs, similar to Medi-Cal, right? So basically, if something is covered under Medi-Cal, then it is also going to be covered under GHPP, and it is different from Medi-Cal in that eligibility for GHPP is not income-based, right? So we understand how Medi-Cal works. You have to meet certain income requirements in order to qualify for Medi-Cal. Your eligibility for GHPP is based solely on your covered condition and not on your income. They do, however, still require patients to file financial information annually. And the reason for that is based on the patient's income, they may be charged an annual enrollment fee. So that's a one-time fee that they pay each year that they are enrolled, and it is based on their income. So many patients qualify for GHPP with no annual enrollment fee, but they may come back with an annual enrollment fee. And if that annual enrollment fee is something that is difficult for the patient to pay all at once, they can set up a payment plan for that. So where they would divide that payment over the course of maybe like a quarterly payment. I don't think they typically do monthly. Next, thank you. We went on to the next slide. The minimum age is 21 years old and older. Again, there is a slight clarification here. So basically, when GHPP was created, it was created to bridge the gap for patients who were on CCS that then lived beyond CCS, right? So CCS, as we know, is only up to age 21. So when the patient turns 21, they no longer have CCS coverage. And what they were seeing was that some of these patients that at the time, remember this was back in 1975, patients with hemophilia, for example, or sickle cell or cystic fibrosis, they weren't necessarily living very long lives. They weren't living long into adulthood, but some of them were certainly living beyond age 21. And this program was created to have somewhere for those patients to go when they no longer qualified for CCS. So again, minimum age is 21 years old. Now, I have heard of a few rare cases where a patient under 21 is able to qualify if they are rejected by CCS and they have a qualified covered condition. So that's a little caveat to that age requirement. You must have an approved genetic condition. Again, we talked about this: hemophilia, von Willebrand, sickle cell, cystic fibrosis, and others that are identified on their website. You must be a resident of California. And I'll pause there to comment, they don't require anything that shows immigration status. They are only requiring documentation that shows that you live here in the state. So something like a utility bill or a rental agreement or something along those lines is sufficient to establish residency. And then your eligibility is not determined by your income, but based upon your income, you may have an annual enrollment fee. Next slide. So this might seem like a little bit of a different question for those in the sickle cell community, because certainly we have just as many women that are impacted by sickle cell. But in the bleeding disorders community, you know, women have struggled to get treatment and proper diagnosis. And so that's come up as a question. So yes, women are eligible for GHPP. Again, the eligibility is based upon the diagnosis. And it's really important in our community that we don't use language that just says that the woman is a carrier of the disorder, because that the providers often will then assume that they aren't actually affected by the disorder, and then they won't approve their GHPP. But if they are symptomatic and they have a diagnosis, they should be able to get GHPP. So what does GHPP cover? So special care centers are definitely at the top of the list for GHPP. GHPP does a better job sometimes than Medi-Cal in understanding the importance of the specialists and the experts treaters in our communities of, you know, rare disease patients. So special care centers, but also hospital stays, outpatient medical, pharmaceutical services, including home infusion therapies, surgeries, durable medical equipment. Again, pretty much anything that is covered by Medi-Cal should be covered by GHPP. And we do have, and I think we'll speak to this later, but we do have many patients who are dual enrolled in Medi-Cal and GHPP. And if you qualify for Medi-Cal, then if you have an eligible condition, you will qualify for GHPP as well, with no annual enrollment fee. The big question at times is like, oh, well, if I already have Medi-Cal, then what advantage is there to having GHPP as well? And where I do find that that can be helpful is sometimes if a patient is in a Medi-Cal managed care plan and they are having trouble accessing the specialists that they need, sometimes that is where GHPP can help kind of circumvent some of the Medi-Cal managed care issues and get you to the specialist that you need. And again, if you're qualified for Medi-Cal, you're going to qualify for GHPP with no annual enrollment fee. So there's really no disadvantage for the patient. Next slide. Okay, here's where we're going to dive a little bit into what the application process for GHPP is like for those that may not be familiar with it. So GHPP application and referral forms are available on their webpage under how to apply. And there's actually 2 documents, and they have both of those on their website in English and in Spanish. I recommend that if possible, you try to submit your paperwork 2 months prior to when you need that GHPP to start. So for young people transitioning from CCS, 2 months prior to their birthday when they're going to turn 21. If you know in advance that your insurance situation is changing, go ahead and get that application in as soon as possible. Again, recognize that's not always possible. Sometimes people have, you know, changes to their employment or their insurance, and it happens quickly, and they need to just, you know, turn it in as quickly as possible in this case. Make sure that you include both Parts A and Part B. Some of this is, you know, probably going to sound obvious, but a lot of applications get returned simply because people don't, you know, initial all the places where they could initial, or they leave out one of the required documents. So the most current tax return is the traditional way to demonstrate income. But again, if someone's income has changed since that, particularly if it has gone down, they can submit pay stubs that show that like there's been a change in employment situation and that their income has decreased, a copy of some type of California ID, and proof of residency. New applicants must include their medical reports, which can demonstrate an eligible medical condition. So this needs to come from a physician, either diagnostic testing, so it could be genetic testing, depending on the covered condition. It might be blood work that demonstrates a diagnosis, or notes from a physician that clearly document like this patient has this condition. So like this patient has sickle cell, or this patient has hemophilia, for example. Documents can be submitted to GHPP 3 ways, and the contact information again is on their website. You can submit via email, fax, or by mail, US mail. I find that email is the most effective way to submit these documents. If you submit them to GHPP via email, then you really have a record of what you submitted and when you submitted it. And that is much easier to follow up on than saying, hey, this got mailed, but I don't know when it got mailed. Or, hey, it was mailed, but it was mailed on this date, for example. And also that way, if you do need to follow up with them and resubmit everything, you already have it on your computer. So whenever possible, I encourage patients, please submit it via email. And it's the GHPP eligibility at dhcs.ca.gov is the email for those submissions, which again is on their website. Next slide. So as far as accessing the services that you have available to you via GHPP, this is the part that does admittedly get a little bit trickier for patients, right? I said, you know, all of these different treatment options are available under GHPP, but because there's only 1,500 patients in the entire state of California on GHPP, most providers are not familiar with GHPP. So this is where we can, particularly if we can educate our specialists so that they become familiar with how to submit their reimbursement. And then when patients have sort of an outside provider, maybe a primary care or an OBGYN, for example, that might be familiar with this, we can really walk them through it. Any provider that is approved as a Medi-Cal provider can submit for GHPP, and GHPP has an explanation and documentation on their website for providers as to how to get reimbursed for treating patients with GHPP. But sometimes we really have to like directly provide that information to the provider to really be able to move things forward if, again, they are not a provider that is familiar with GHPP. So examples that I see of that are somewhat common is like, for again, our hemophilia treatment centers are very familiar with GHPP and they know how to get reimbursement through there. But if the patient, for example, say has, needs to see an orthopedic surgeon, the orthopedic surgeon's office might need some hand-holding to kind of know like how to submit this claim via GHPP. Next slide. So this is geared towards the patient, right? So the patient's responsibility, you must meet the eligibility requirements and pay the annual enrollment fee if that is applicable. You do have to update your enrollment annually. This is one of the things that frustrates patients. The reason that this takes place is, again, because they are asking for that financial information to figure out whether or not the patient is required to pay that annual enrollment fee. So you do have to, renew your application every year. It's the same application with the exception that they do understand that these are genetic conditions and that the diagnosis is not going to change. So once you have documented your medical condition, you don't have to continue to send in that documentation, but the rest of the application does have to be completed and updated. We also encourage patients, and this is just like Medi-Cal, right? And our Medi-Cal patients, make sure you keep your contact information, your email, your address up to date with GHPP, so that if they send you a notice or a reminder that you need to renew soon or anything like that, that you will get that and get that documentation when they send it to you. Again, also, particularly if you have an annual enrollment fee and your income goes down, you do want to update them on changes to your financial status. And they will require you to do that each year with your renewal. And then again, this is something that folks are not always aware of, but GHPP, as I said earlier, it can be combined with Medi-Cal. It can be combined with Medicare. Excuse me. And it can be combined with private insurance as well. Now, GHPP will always be the payer of last resort. So those other players will always come first, but depending on your financial situation, it could be helpful to have it as a secondary. So as we were talking about, you do have to renew annually, and the process is similar to the original application. So typically the department will mail out renewal applications about 2 months prior to the expiration of eligibility. However, I have seen situations where for some reason GHPP did not mail them out timely. Recently we had a snafu where they were dated correctly, but then they must have sat in some place somewhere and didn't get dropped in the mail because the postmark on the letters was like a full month after the date on the letters. And so we always recommend that patients, mark their calendars and they complete their renewal as soon as, a couple months ahead of that time in order to avoid any delays or expiration of eligibility. As I mentioned, it is the same as the original application, and all the same documentation is required except for the documentation of the genetic condition. Next slide. So GHPP has an interesting little side program, which is also not typically well known about. It's called the Health Insurance Premium Reimbursement. This is for a patient who may have private insurance and they are paying a portion of the premium for that insurance. So for example, you have employer-sponsored insurance, but maybe 20% of the cost of the premium comes out of your pocket or out of your paycheck each month. If you qualify for GHPP, you may also qualify for the health insurance premium reimbursement, which means you can submit copies of what you paid for your premium and GHPP will reimburse you for that. The reason and the rationale for this program is that if you qualify for GHPP, in the long run, the state saves money by having your primary insurance be through your employer, and they pick up most, if not all, of your cost of your care, and then GHPP reimburses you for the premium. Now, this does not cover co-payments or deductibles or co-insurance. It's just for the cost of the premium. And it does not apply to Medicare or Medi-Cal. It is only if it is a private health plan and you are paying a portion of the premium out of your pocket. Any questions on HRPA? Because that's one that people often have questions on. I don't know if I'm seeing the whole chat, but I don't see any questions at the moment. So we can always come back to that if there's more questions later. Yeah. So here is the address for mailing, as well as, again, I mentioned this earlier, but it's GHPP eligibility at dhcs.ca.gov. is the email address, and that is the primary way that I encourage folks to communicate with GHPP. It is not easy to talk to someone on the phone at GHPP. If you do have a client who really would do better with a phone conversation, you probably will need to email them initially and then see if they can have someone from the eligibility group call you or call that patient back. But they tend to prefer to communicate in writing via email or mail. Next slide. Okay, so switching away from GHPP a little bit, we'll talk a little bit about CCS, which I feel like has in general more understanding and folks are more aware of the program. California Children's Services is a state-funded program for children up to the age of 21. Again, similar to GHPP, you must have a qualifying condition. One of the big differences between GHPP and CCS, aside from obviously they cover different age groups, is that CCS only covers treatment related to the covered condition. So if you are on CCS because you have sickle cell disease, it's only going to cover treatment related to your sickle cell. These are children that are on CCS, right? So you have other routine well child visits, vaccinations, accidents, common colds, all of those things that happen sort of routinely for children and why they might need medical care. Those things are not going to be covered by CCS. So unlike GHPP, which can be standalone insurance for an individual, CCS should always be combined with other insurance. So it's always going to be combined typically with Medi-Cal. So you're going to have a patient that's Medi-Cal / CCS, or it could potentially be combined with their private insurance if they qualify based on their income. Because again, CCS is based on income qualification. Next slide, please. So who qualifies? You must be under 21 years old, and you must have a health condition covered by CCS. Now, the list of conditions that are covered by CCS is much, much broader than the list of conditions covered by GHPP and much more common. Children that, suffer with cancer, for example, are covered by CCS, but not by GHPP. When you compare the numbers, there are around 200,000 patients on CCS in the state of California, and as I mentioned earlier, only 1,500 on GHPP. You still must be a resident of California, and you must meet one of the qualifying financial criteria, of which there are 6. I won't go through all of them right now, but essentially, if you're covered with Medi-Cal, you're definitely going to get on CCS, and then there are some other things like 20% of your income having to go to medical costs is another way that families can qualify. So if you have a high cost medical care and you don't qualify for Medi-Cal, you still might qualify for CCS. What does CCS cover? So CCS covers quite a variety of things: doctor visits and care, hospitalization, surgery, physical and occupational therapy, x-rays, diagnostics, medical condition, but only for the covered condition, right? Another hallmark of CCS is medical case management, right? So CCS children should have an assigned case manager that's helping families coordinate care and referring you to other resources potentially, such as a regional center or other public health nursing, et cetera. And even now with Medi-Cal managed care, and in a whole child model counties where, our CCS kids are in managed care, there are requirements on the managed care plans to still be able to provide all of this medical case management. And that is something that groups like ourselves, we have a representative on the California, or the CCS advisory group, I should say, representing the Hemophilia Council, and other groups such as Family Voices and the California Children's Hospitals Association are really continuing to monitor very closely to ensure that those CCS kids are still getting all of the services that are supposed to be provided under CCS. So if you become aware of situations where that is not happening, please reach out so that we can advocate on behalf of those children and also let the department know if this is a more systemic problem. So again, all of those must be medically necessary services, but if they're related to the covered condition, you should be able to get access to those. So the process is slightly different. Technically, there must be a referral that happens. Often this happens in the hospital setting. So a child is either born with or ends up in the hospital and receives a diagnosis that would qualify for them for CCS. And they're then at that point, through the social worker in the hospital setting and or the even like the billing department, they should be referring the patient to CCS and helping to get that application submitted. But technically anyone can refer, including the parent, right? And so they could complete that referral and submit the application to CCS. Another thing that's a little different is because CCS is such a larger population, it is managed at the county level as opposed to GHPP, which is managed at the state level. This can be a little bit frustrating at times because while guidance is set by the state and there should be equity across counties, not every county CCS office operates exactly the same way. And so they are the ones that are going to review the applications to determine eligibility, and they're going to ask for documents such as a form of identification, things to establish residency, such as, you know, a rental agreement or utility bills, financial information such as taxes or pay stubs, and school enrollment forms or tax returns. And then again, similar with GHPP, at the initial application, you're going to have to confirm medical eligibility, and the documents will always be submitted to your local county CCS office, which again, on the state CCS website, there's a list of all of the counties and how to contact them. Always, always, always keep a copy of all of your applications and documentations and know when and how you submitted them, so that if you have to follow up, you know, you can tell them like when you originally submitted it. In most counties, and again, this is where CCS gets confusing because we have whole child model pilot counties, which have now been expanded this year to additional counties, and there will be even more counties included in 2025. But so in a traditional CCS county, the child CCS eligible condition is the responsibility of CCS directly. It's like a fee for service situation in that county. In whole child model counties, it's the responsibility of the managed care plan. Special care centers and or providers who have that CCS designation should have access to be able to treat these CCS kids. And treatment is provided when prescribed by a CCS approved doctor and authorized by CCS. So there is typically a prior approval process that you have to go through getting the service order approved by the county before services proceed. Next slide. So patients' responsibilities in the CCS program or their families, again, meet the eligibility requirement, including your initial application and yearly redetermination. Notify CCS program staff and providers of any health insurance at the time of coverage. Like GHPP, right? It would be billed to the private insurance first, and then CCS would be secondary. They sometimes will ask patients to apply for Medi-Cal. So if that's necessary, you may have to go through that step as well. And you want to keep your contact information up to date and make sure that they're aware of any changes that might affect eligibility. Next slide. Also, notify CCS when your child is receiving services from a medical provider, which again, the providers should be doing that for the families, but it could be a situation where, you just want to keep in communication and make sure that the provider knows that this is a CCS patient and that needs to be taken care of. Keep all appointments and follow treatment plans. Inform CCS of any medical emergency. And remind CCS to notify, or provider, I should say, to notify CCS of any changes to the treatment plan, termination of treatment, and sending reports to the local CCS office. Again, because the neck conditions are broader under CCS, some of these may be situations where the patient will be cured of the disorder or the disease that was impacting them, and may not need CCS anymore. In general, that isn't true for our patient populations, but it could be for some in CCS. So how are the renewals handled? Again, CCS renewals are handled by the local county office where you live, and so the process can vary a bit from county to county, but you should have an assigned person in your county that is your contact that should notify you when you have eligibility up for renewal. But like GHPP, I never want patients to be dependent upon that. I really want folks to take responsibility and encourage them to plan ahead, know when the renewal will be coming up, and be sure that you reach out early and get that renewal completed timely so that you have no disruption of service. Next slide. So how to get help. Again, this is generally, you're going to reach out to your county office for more information. And we always let patients know they can reach out to us as well if they're having trouble finding the right contact. We do have some contacts in some counties, but we also have contacts at the state that can reach out to individual counties if they're having a problem. Next slide. Okay, and these are things that are true for both GHPP and CCS. So what are some of the things that happen that causes a delay or a denial? A lot of this is just like follow the instructions on the applications and the documentations, right? You didn't submit a photo ID, missing verification of residency, missing verification of income, pending medical eligibility. And sometimes that is just like maybe the provider notes that you sent were not sufficient, right? So make sure that they really clearly, that it's a physician, one, and that they're clearly documenting the diagnosis. An incomplete application, and then there are multiple places to initial and sign. So you really have to go back through and double check that you've initialed and signed all of the places where that is needed. What else to watch out for? So this has been a big point of confusion in the past. A BIC card, so that's a benefits information card. In the past, we've been told that all GHPP and CCS beneficiaries should receive a BIC card, a benefit information card. But we have had many people tell us that they never received them. Part of the issue is that I believe what happens is they send them out when the patient is first approved, and they don't get a new one every year like you would with your insurance or with Medi-Cal. And so people lose track of them, or they get very, very old. We do now have a process by which we can help patients, particularly GHPP patients, request replacement cards. CCS beneficiaries should be able to get those through their CCS county office and contact. As I've mentioned several times also, patients should know when their renewal date is and mark their calendar to submit that about 2 months ahead of the renewal date. Don't wait for you to get that information from GHPP or CCS. There might be a mistake. It might not get sent. It might get lost in the mail. You might have forgotten to update your address. Lots of things can happen, and we want to try to avoid any sort of disruption in coverage if at all possible. And then I touched on this when we talked about GHPP. The biggest challenge can be just having providers that are unfamiliar with these programs, and you might really have to assist them in knowing how they can get reimbursed, which can be a barrier, right? They may not want to accept a patient if they don't understand whether or not they're going to get paid for the services that they're providing. And so you may have to look for a provider that's willing to then, you know, look at the links that you send, etc. And it can be a little bit daunting sometimes for patients in this situation to have to sort of walk their provider through how to get reimbursed for their services. It's not really a reasonable expectation, right? You can go ahead and go on to the next one. So we want to encourage, and I think that this is where there's like huge value in collaboration between like various patient communities. As of right now, we don't believe that these programs are at risk, but given the current budget situation at the state of California, you know, that could change in the coming months, or certainly in the next couple of years if we continue to have down budget cycles. So you know, utilizations of these programs is very important. We want to know how they're working for your patients, and we want to collaborate in getting problems solved, and then collaborate in continuing to advocate for the existence of these programs and that the state continues to fund them. So looking forward to being able to, you know, continue that work together and collaborate on that to make voices heard. Next slide. How to, you know, some ways to kind of monitor this information. You can go on our website and sign up for updates. Some of the things may not be, you know, exclusively relevant to you as sickle cell providers or sickle cell community members, but a lot of the stuff that we work on is, like I've said before, across rare disease. And so there may be helpful resources for you. And then we do have a monthly webinar series, and we do cover these topics geared at patients. So feel free to, you know, share those with those that might benefit from participating. And, you know, while we really do focus on bleeding disorders in our organization, we are still happy to be a resource and to leverage the resources and the relationships that we've built with the department if any of you are having problems with a CCS or a GHPP issue. So I have had, you know, social workers, providers, patients reach out to me in the past on these issues, and, you know, I'm not going to turn any patient away that needs help. We'll do our best to point you in the right direction and help you get resources. So please feel free to reach out if there's an issue that, you know, you or one of your community members is facing. All right, so I think we're at questions. Covered a lot of that pretty quickly, and I know we still have a good chunk of time left if folks have questions. So happy to field some of those if you have any for me.
Thank you,
Absolutely.
Lynne.
Go ahead.
I was just going to thank Lynne for coming in. I'm sorry I was a little late earlier, but I can go ahead and run the questions if that's okay with you, Niani?
Absolutely.
Great. So we have a couple in here, and I also have a couple noted down. And again, thank you for your time, and we really appreciate kind of your partnership on this, all this information that you are sharing with us. I think it's really valuable. So we'll go ahead and get started. So one of the first questions on here is if you know what the kind of general dollar range is for the GHPP annual fee.
Yeah, so it's always been a little bit of a mystery. Like, we've never been able to get them to give us like a clear answer as to like what the fees are. But what I would say is that many patients do not have any annual enrollment fee. And I have never really seen an annual enrollment fee that's much more than like, say, $3,000, which, if you think of that as a replacement for someone's health insurance, $3,000 for an entire year is pretty cheap. Now, I recognize that for many patients, that's still a lot of money. But again, they will work with folks and give, you know, a payment plan, et cetera. And I think that that's really because also, like, much higher income earners are more likely to have insurance through an employer and are less likely to maybe apply for GHPP. But I will say, like, and just to add on to that comment, I will sometimes tell patients, depending on their situation, it might be worth applying for GHPP and seeing what they would, what they're going to come back at them with as a annual enrollment fee. And then you really have to assess like the coverage that you have. If you have employer-based coverage, how good is it at meeting your needs? And then is it worth the annual enrollment fee to add GHPP on? So it does become a little bit of an individual decision, depending on the patient's specific situation. And also it might be a trade-off, right? Like we talked about that health insurance premium reimbursement. They may have an annual enrollment fee, but how much could they potentially get back by having their premium reimbursed, right? So they may come out ahead even with an annual enrollment fee in that scenario.
That's a great point, and actually leads in really nicely into this next question. It says, I'm caseworker from Children's Hospital, Los Angeles, working with sickle cell and hemophilia patients. We have patients we see that turn 21 and providers want the patient to apply for GHPP, but the patient has a medical group that is covering and thus will not qualify or be approved for GHPP. Should I still have the patient apply, even if they have a qualifying medical group, and we will continue to see for medical care?
Yeah, so I think I'll answer this a couple ways, but one is, so they're already, if they're turning 21 and coming off of CCS, they're probably getting their coverage at that point still potentially through their parents' insurance, most likely. Not a lot of 21-year-olds have like great health insurance on their own accord at that point. So if they are, it can be easier to transition onto GHPP if you're transitioning directly from CCS, because you don't have to resubmit medical eligibility because the state already has documented your medical eligibility. So I don't think it hurts anything for them to go ahead and submit the application and apply. The only reason really to turn it down would be if they came back and said, oh, your annual enrollment fee is, $3,000. And they're like, well, my primary insurance really covers everything. So why would there's no real value to me paying that $3,000 to have GHPP as my secondary, right? They will not get declined based on having other coverage. That is not a reason for GHPP to decline them, but GHPP will always be the payer of last resort. And so if they have other coverage, that's going to go, everything's got to be billed through that other coverage first. And what GHPP will not do is pay like a copay or a co-insurance on your behalf. So if your primary covers it, but you still have, say, like a 20% co-insurance, that GHPP isn't going to kick in on that. GHPP is only going to kick in if the primary declines to cover the treatment. So hopefully that's helpful context.
Yeah, I think that is. And John, if that doesn't fully answer your question, feel free to kind of add some more to that. Another question we have is whether most care providers for adults with sickle cell disease, which you may or may not know about GHPP. Do you have a sense?
That's a great question. And I don't know the answer to that. I think that in the places that, the folks that are involved in like this organization and Networking Sickle Cell for California are probably at least aware of it and have a growing knowledge base of it and resources available to them. If it's a sickle cell provider that's kind of outside of that network and isn't super active, they may not be aware of it. Because I do think that when I look at the numbers, so when we get an update quarterly from the state of how many patients are on GHPP, and like I mentioned, there's about 1,500 patients in the whole of the state, and over 600 of those are patients with bleeding disorders. And when you think about the size of our patient populations, I think that sickle cell
Yeah.
should probably make up a larger component of that number. And so my sense based on that is it's being underutilized.
Yeah, I didn't realize those numbers. Those are kind of shocking to hear.
Yeah, they're small, and I haven't specifically asked them for the sickle cell numbers. But if if the network wants to do that, I can help you know who to reach out to, and I think they would be happy to give you those numbers in terms of how many patients are on GHPP and CCS with a sickle cell diagnosis. I would just need the diagnosis codes, and the state could request that. I mean, we could request that info from the state.
Thank you. And another follow-up to that was whether any of the HTC clinics are also comprehensive care clinics for sickle cell disease.
I think CIBD would fit
CIBD.
that
Yeah.
bill. I'm not sure if there are any other that are like fully kind of integrated that way. But I know there's a lot of institutions that have both, right? Like I think at like UCSF, I don't think they're in this. You guys are not in like actually the same centers, but like operate separately. UC Davis, I think like there's a hemophilia treatment center and a sickle cell center. That's not totally my expertise, but
yeah,
I think you have a lot of them at the same institutions, and I think there's probably variation between like how much they're working together.
Thank you. And we have another question from Judith Baker, who's curious about how the new CalAIM benefits, specifically the enhanced care management and community services, are being implemented for CCS GHPP insured folks. Is there any proactive communications from your kind of program with DHA specifically for the CCS and GHPP insured?
Yeah, so that's a great question, and I feel like it's one of those things that like the department has been talking about for a long time, and hasn't always been super clear like how it's actually like working out into benefits for patients, right? But I do think on the CCS side, it's more clear that they have been, putting these requirements in place to give access to some of these enhanced care management services. On the GHPP side, it's less clear because it's such a small department, and all of these different groups at the state level don't always talk to one another as much as they could. Now, we learned something very interesting from the state just last week, and that is that the management of GHPP, which historically, well, in recent years, I should say, has been split between the Integrated Systems of Care Division and the Clinical Assurance Division. One side doing like policy and enrollment, and the other side like processing actual claims. It's all coming back under CAD, under Clinical Assurance Division. So I think that we have some opportunities with that as they complete that transition, which is, they told us last week, is supposed to be completed probably like by mid to late summer. That we can have some clearer conversations with the leadership of CAD to see how can we really leverage that, those CalAIM initiatives for our GHPP patients. And again, keeping in mind, a good number of those patients are dual enrolled in Medi-Cal and GHPP.
Right.
So it doesn't completely answer the question, but that's kind of my take on it.
I mean, it's good to hear that it's on the mind of some folks, though, even if there's not any clear direction just yet. One thing you mentioned earlier was about having to potentially handhold some of the providers that are maybe not as familiar with GHPP on how to submit a claim. Yep. Is that, from a patient perspective, like how are there resources to help the providers kind of walk through that process? How it just seems like if a provider can't figure it out, how would a patient be able to figure it out?
I know GHPP used to tell us like, oh, we'll just have a patient take a copy of their SAR. And I'm like, a patient isn't even going to have a copy of their SAR. Like, how are they going to, how would you expect them to be able to walk a provider through that process, right? Like, imagine if our insurance companies, like patients who had regular, commercial insurance, were told that you have to go tell your provider how to bill their insurance company and explain it to them. The state would immediately come along and tell the insurance companies that that's not a reasonable expectation. So it is a little tricky. I think that is where, like, the special care centers can hopefully be a resource, like one provider to another, saying, hey, this is their coverage, this is how you bill it. But we do have a couple of options that we can try to help hook providers up with. And so one is obviously just giving them the resource that the state has in terms of how to bill, which is on the webpage. The other thing is that Gainwell, who's the fiscal intermediary, they can provide training for providers. But sometimes the reality is it's just, you kind of have to find a provider that's like willing to put that effort in, right? If they're putting all that effort in and it's one patient that they're seeing, they may or may not be willing to put in the time to figure it out. And we all know that there are many providers that go that extra mile, and then there are others that there are some out there that just probably aren't going to do that. So we don't have currently a really great resource for patients on that. That's one of the things that's been on my to-do list for a while, is even just coming up with like a one pager that we can give patients to give to their provider, right? To say, here's how to do it, and here's who to call if you have questions, and even put our own resource out there in that case.
Great. Let's see if there's any other questions from folks while we have Lynn on the call. I have one last question while we see if anyone else has any additional questions. In terms of the special care centers, have you encountered there being issues with patients being too far away from specialty care centers to be able to access kind of that resources that are housed there? And is there any movement to maybe make panel more clinics to be a specialty care center?
That's a great question. I do know that that is certainly an option, right? Actually, the department commented on that as well last week and indicated that they are trying to get more providers paneled, and but they admitted that they're sort of behind in the processing of applications for paneling providers. Now, that wasn't specific to sickle cell or bleeding disorders. I don't know that there really is. I'm not aware of a lot of movement in terms of creating more special care centers on the bleeding disorder side. I do think that's more of a movement on the sickle cell side, right? To try to get funding for that. It's a real struggle in the state budget situation right now to get that money from the state. So I think that's going to continue to be a challenge. But that's also going back to the CalAIM conversation. That is also where some of those extra resources through Medi-Cal or being able to access that CalAIM beneficiary for like a GHPP or a CCS patient could be helpful, because there are supposed to be resources to help patients get to centers that are further away in that, whether that's a gas card or transportation of another sort, or, being able to provide an overnight stay or food vouchers or things like that. Some of those types of resources are in there, because to some degree, there are always going to be gaps, right? You're always going to have, in a state that's geography is like California's is, and when we're talking about rare disease patient populations like hemophilia or sickle cell, you're never going to have a qualified provider right by every patient, because there just aren't enough of our kinds of patients to have them everywhere. You're going to unfortunately have some patients that are going to have to travel further distances to get to their providers. But that's also where In addition, I would say that's also where telehealth can be beneficial as well. And post-COVID, we do have some more flexibility in some of our telehealth options as well, because maybe not every visit has to be in person, right?
Right. Great. Don't see any more questions coming in. So, but I will leave an open invitation if people have any questions that come up. Feel free to email them to us, and we'll do our best to get those answered. And I'll pass it back to Niani. And thank you again so much, Lynn, for this.
Thanks for having me.
Yeah, absolutely. Thanks so much, Lynn. It's really insightful, the level of detail you went into. So hopefully it's really helpful for folks both on the call and that will be listening to it later. At this time, you'll see on the screen all of the various ways that you can get in contact with us and our organization, keep up with our webinars and all of the great work that we are doing and folks are doing in collaboration with us here. I'll leave that on the screen for a moment to copy that QR code, and that will add you to our newsletter, which will give you access to our annual newsletter as well as the webinar sign-ups. And then I am not seeing any other additional questions or anything come in. So then that will conclude the time that we have for this session. I just want to thank everyone for their attendance as well as participation. Upon conclusion of this webinar, there will be a 3-question quiz. Please take the time to fill that out. If you have it, it should take you about 2 minutes or so, and it allows you to provide feedback on the webinar as well as ask additional questions that you may think of and provide feedback on future speakers. Thanks everybody for your time. We'll talk to you next quarter.